My role in this course, what I do for it every year, is to talk about North Carolina communicable disease law. And this is something that I have worked on. Let me see if I can adjust my camera a little bit. Maybe that's a little bit better. This is something that I have worked on for my entire career here at the School of Government, which now goes back 20 years, unbelievably. And in fact, I've written a book on North Carolina communicable disease law, which I will refer to later and give you information about if you are interested. I'm not in the business of selling books, but I do want you to know that that resource is available to you if you want it. When I did my research for the book that I wrote on North Carolina communicable disease law, one of the things that I did was look at a collection that we have here at the University of North Carolina Libraries. We have the North Carolina Health History Digital Collection, which is, if you're into research, it's a very cool archive of documents, including annual reports about public health in North Carolina that goes back to the 1800s. And so I have gone back and read some of these old reports just to see what kinds of diseases people have been concerned about at different times in the history of our state. I found the 1919 report that what was then called the North Carolina Board of Health did on the Great Flu of 1918. If you've done any work with flu, you've probably heard about that. In the mid-20th century, our Health Digital Library shows that everyone was concerned with polio. There was an outbreak that was described in the State Board of Health report as, in 1949 as the most widespread epidemic in history. And then 30 or 40 years later, we weren't talking about polio anymore because we were just beginning to come to terms with the reality of HIV in our state. So that's some old history. More recently, a few years ago when I spoke to this group, we were in the middle of the part of the Ebola outbreak that affected the United States with a couple of cases that we had here. This year we've got a lot of interesting stuff going on. I didn't expect to be in the middle of a town with a boil water advisory when I signed up to teach you today, but nevertheless, there I am. It's not the first boil water advisory that we've had this year because Hurricane Florence created a lot of communicable disease concerns from water contamination, potentially including contamination with communicable disease bacteria. Hurricane Florence also created concerns with mosquito-borne illnesses and Vibrio-infected shellfish and the disease concerns that those create. We've been watching an increase in hepatitis A for a while in North Carolina. And today, even as we speak, we have a varicella outbreak that's affecting a school in Buncombe County, and that has resulted in the issuance of some orders there that I'll be talking about later that you might find interesting. My point for now is just to say it is always something in communicable disease. So, we've progressed from polio, HIV, the epidemic has gotten better in some ways that I'll be talking about later, but it's always something. There's always something to be dealing with. A report that the World Health Organization put out a couple of years ago on tuberculosis noted that one thing that all of these different types of communicable diseases have in common, whether it's TB or whether it's Ebola or something else, is that they tend to flourish in places that have poor medical infrastructure. And that's true. What I want to inform you about is that we also have a public health infrastructure for communicable disease control, and one piece of that infrastructure is law, and that's the part that I study and that I will talk about now. Now, I believe that I am the one in control of the slides. Is that true? If that is true, let me see if I can figure out how to advance them. Okay, I'm going to need some help, I think, in order to advance my slides. Is that something that can be done, Amy, from your screen?
Yeah, I'm going to work on that.
Is that something that you can send me a message about? From your screen sounds perfect. We'll go from there if you don't mind. I'll just let you know when I'm ready for the next slide, and thank you very much for that. I wanted to sort of lay out a legal framework for communicable disease control in North Carolina. It includes provisions for the detection of communicable diseases or conditions within a population. It includes provisions for investigating cases and outbreaks for public health officials to conduct those investigations. Our legal framework also includes communicable disease control measures that specify the steps that individuals, healthcare providers, public officials, and sometimes other people are required by law to take in order to control the spread of a communicable disease. The framework includes legal remedies, which is the term that we use to describe the legal tools that we use to enforce communicable disease laws. And then the legal framework also includes access to and protection of the confidential information that is often necessary to carry out communicable disease activities. Next slide, please. Communicable disease law is one part of the larger body of public health law, and I like to point out that public health law is a little bit different from general healthcare law. The focus in public health law is on the legal authority and the legal duty of public health systems, which are governmental systems. We have other people, obviously private actors, who interact with governmental systems and carry out their own activities in different ways that affect the public health, but public health legal powers and duties are a governmental function. Governmental public health officials often sort of fly below the radar. I doubt that most of the citizens in our state even know who their local health director is, let alone what that person does. But these officials are key players in communicable disease control. They have a fair amount of authority to investigate diseases, and they even have the authority to tell people what they have to do to control disease spread within their community. Their legal authority and the duties of the public health system are the focus of my work in this area, and they're part of public health legal authority. So the next slide, please. I'm going to try adjusting my camera again because I feel like I'm looking at you sideways. Let's try that. Okay. So the Ebola outbreak of 2014 drew to people's attention, I think, the extent to which public health legal authority is exercised more by states than by the federal government. I don't want to downplay the role of CDC or other federal agencies. They certainly play an important role in developing the science that's important to the exercise of legal authority and the guidelines for implementing communicable disease legal authority. And they also even put some of their personnel on the ground in states that are dealing with communicable disease issues from time to time. And I'll say more about that in a minute. But what I want to focus on for now is the reality that an awful lot of communicable disease control law is state law in the United States. So it's enacted, adopted by individual states, and sometimes there are slight variations from one state to the next. So if you've practiced somewhere else and then come to North Carolina, or if you start here and then go somewhere else, you might notice that there are some minor differences around some of the issues that we talk about. The reason that this is a matter of state law in the United States is because it's our states and not the federal government that exercise something that we call the police power. Now, what does that have to do with public health? First of all, I would like everyone to set aside any mental picture that you may have of police officers, because that's not what I'm talking about when I use the term police power. What I'm talking about, the police power, is the authority of government to protect the safety, health, and welfare of the population. In North Carolina, both our local and our state public health officials exercise some of this power. So how and to what ends do they exercise their police power? In the communicable disease realm, the state has adopted laws addressing everything that you see here. So they've used their police power to adopt this comprehensive approach to communicable disease control that's set out in state laws that address preparedness, prevention, which includes immunizations and environmental health activities, as well as actions that individuals might need to take, detection of communicable diseases and conditions, and disease control measures, usually something that comes short of isolation or quarantine, but potentially including those. So I've mentioned those on the slides. And then also we have laws that provide methods for enforcing the communicable disease control laws. Local public health officials are the ones who carry out a lot of these duties in North Carolina. They perform the specific activities that are needed to make this work from day to day. But in North Carolina, the local officials are getting their authority to do that from state level laws. In some states, there's more local authority than we have here. Here in North Carolina, it's mostly coming from the state. And most of the state laws apply to communicable diseases that are in let me back up. I need to start that sentence over. What I was trying to say was that most of our laws addressing communicable disease in North Carolina are in the form of either what we call statutes or what we call rules or regulations. And you may know what those are, but let's do a real quick civics review on that, starting with the next slide. Okay, the North Carolina General Statutes are the laws that are enacted by the legislative branch of our state government, which is the North Carolina General Assembly. We have laws that require physicians and certain others to report communicable diseases and conditions to public health officials. We have another law that requires all persons, that's everyone, to comply with communicable disease control measures if they have or are believed to have or have been exposed to a communicable disease or condition, then those laws apply to them. We also have a law allowing either the state health director or a local health director to order isolation or quarantine. Part of that law provides what we call due process protections for individuals who are isolated or quarantined. And what that means is that it gives people who are subject to those orders a way to have the orders reviewed by a court. And then we also have statutes that address the confidentiality of communicable disease information and when and how you have to get informed consent and when you don't for some communicable disease tests or treatments, and also methods for enforcing the communicable disease laws. And all of that's in statutes. Over on the right-hand side of the slide, I have given you an example of how we cite laws in North Carolina so that you'll know what you're looking at when you see this collection, this string of letters and numbers that lawyers are so fond of in our citation system. In North Carolina, GS 130A-135 refers to a particular chapter, 130A of the North Carolina General Statutes, and then 135 is a particular section within that chapter that addresses one of the issues we're going to be talking about today. If you ever want to read the statutes themselves directly, word for word, what they say, instead of summaries like the ones that I write about what they're about, you can get to them online. And the link to the website is available on the slide. That is the link to the North Carolina General Assembly's website. I talk about statutes first because they're really important in communicable disease law in North Carolina. They're the most important laws that we have. They give us our general framework for our communicable disease laws, but they don't give us all the specifics that we need to know in order to control particular outbreaks or cases of communicable diseases. Give you an example. We have a statute that says we're going to have required communicable disease control measures, and we're going to say everybody has to comply with them. And the statute says that, but it doesn't tell us what the communicable disease control measures are that we all have to comply with. Instead, it says, well, we're going to have rules that address what those control measures are going to be. So the next slide, we'll take a look at North Carolina communicable disease rules. Rules are a type of law, sometimes called regulations. You can use those words interchangeably and it's fine. Legally, they mean the same thing. But they're a type of law that's adopted by the executive branch of government rather than the legislative branch. Now, we all remember civics class that the legislative branch is the one that makes the laws, and that's true. But the executive branch sometimes has a pretty significant role in fleshing those laws out by exercising this rulemaking authority that is delegated to it by the legislative branch of government. So in North Carolina, we have a body called the North Carolina Commission for Public Health that has been authorized and directed to adopt communicable disease rules. It's also been authorized and directed to adopt other categories of public health rules, but today we're talking about communicable disease rules. The commission is a 13-member body with 9 that are appointed by the governor and 4 that are appointed by the North Carolina Medical Society, and the composition of the membership reflects the professions that have expertise that is highly relevant to public health activities. So we've got physicians, a pharmacist, a nurse, a veterinarian, an engineer, and other people who are represented on that commission. The Commission for Public Health is responsible for making statewide rules on a number of matters, including communicable disease. And when they use that authority and adopt those statewide rules, those rules have the force of law. So that's pretty significant. However, the commission can't just go in and adopt any old rule that it thinks might be a good idea. It can only adopt rules when the General Assembly, the legislative branch, has said you're authorized to adopt rules to flesh out the statutes that we have adopted. We're going to set the general policy in the statutes, and then we're going to give you rulemaking authority to sort of put the flesh on the skeleton that the General Assembly has created with its statutes. So the executive agency's roles is limited to figuring out the details of the policy decisions that the legislature has made. I've mentioned already the commission's been specifically authorized to adopt communicable disease rules, including rules that specify communicable disease control measures that people are required by law to comply with, and that specify which communicable diseases are going to be reportable. And also that address HIV testing. And I highlight that this year because we had a significant change in the HIV rules in North Carolina in January of 2018. So I wanted to use this opportunity of speaking to you all this year to address that with you. I also want to note that the commission is also authorized to adopt rules setting out the childhood immunization schedule and addressing how immunization information may be shared. And that's something that comes up from time to time as well. Okay, let's move on to the next slide and take a real quick look at North Carolina court decisions. If you ever want to look up what the law says about a particular communicable disease issue in North Carolina, it's certainly a good idea to start with our state statutes and our state rules, because they will get you about 90% of the way to the answer to many questions. But I have to say something about the role of the courts and case law, because that is the third branch of government, the judicial branch, and they do take actions that affect how we interpret the statutes and the rules that the legislative and executive branches have adopted. And so what the courts have to say is really significant. You can read a statute or a rule and think you know what it means, but sometimes you don't really know what it means until a court weighs in with a court case that tells you this is how we're going to interpret this law in this state. So, the courts are really important. However, in North Carolina, we have a lot of communicable disease statutes and rules, and we have very few court cases interpreting them, and it's been like that for decades. So we rely a lot on our statutes, our rules, but also on when our statutes and rules have gaps in them or aren't totally clear, we rely a lot on practice and on policy guidance that's issued by the State Division of Public Health in interpreting what the statutes and rules mean. When we do get a case, it's important to take note of it because it becomes part of the law that our practice and our policy guidance has to reflect. So I do want to be cognizant of the role of the courts, and also to point out that we've had some significant communicable disease court decisions in North Carolina, including the ones that you see listed on this slide. Our courts have upheld mandatory HIV reporting that was challenged when it first became a thing in North Carolina in the early 1990s. There was a constitutional challenge, but it's been upheld. Similarly, going way back, our state's immunization requirements for children have been upheld by the courts of the state, and our public health system's authority to enforce the communicable disease laws has been upheld by the courts as well, and all of that's important. All right, let's move on to the next slide. I want to talk a little bit about the state versus, I mentioned that public health is a governmental function. And that's certainly true when legal authority is being exercised, as it often is in the communicable disease realm. Again, not to minimize the role of other actors in the overall system, but if you need someone who's got the legal authority to do something or to enforce something, then generally you're going to have your governmental actors involved. And we have state and local governmental actors that are involved in communicable disease control in North Carolina. So responsibility for communicable disease control is shared between state and local public health officials in the state, but a lot of the legal framework is at the state level, and then a lot of the activity occurs at the local level. But the laws are at the state level, and in an outbreak, I'm gesturing here, but I think I'm off screen, so you can't see it. I'm going state and I'm going local, and I'm doing a little bit of this. So just imagine me being more active than it looks on the screen. In an outbreak, state officials will typically take the lead in developing and coordinating the response to the outbreak, but the actual activities associated with the outbreak are going to be being done by people who work for local health departments in North Carolina. The State Secretary of Health and Human Services is the person who is charged with the overall responsibility for overseeing communicable disease prevention and control in North Carolina. But the Secretary also is required to appoint a state health director, and that's really where the person who with ultimate responsibility for doing the things, that take care of communicable disease cases and outbreaks gets started. The state health director is a North Carolina licensed physician who performs duties and exercises authority that's delegated by the Secretary for Health and Human Services. And right now in North Carolina, our state health director is Dr. Betsy Tilson. She has multiple specific duties in the communicable disease realm, and she also shares some authority with local health directors. So some of the authorities in the communicable disease realm can be exercised by either the state health director or the local health director, and it doesn't have to be both at the same time, and it's usually not both at the same time, but they do have some shared authority. North Carolina also has a state epidemiologist who plays a really important role in communicable disease response. The current state epidemiologist is Dr. Zach Moore. He and I share a last name, but as far as I know, we're not related. We've known each other for a few years and haven't identified any relationship there yet. But among other duties, his role is to oversee the work of the communicable disease branch, which is a component of the Division of Public Health within the State Department of Health and Human Services. So that branch is the one that receives reports of cases of communicable diseases that are made from hospitals and other healthcare providers to local health departments. They go from there to the state, and the state branch receives those reports. They coordinate and conduct disease surveillance and disease investigation activities. They coordinate the public health response to outbreaks. They provide assistance and support to local public health agencies when they're responding to communicable disease situations, and they also provide public information about communicable diseases. Now, I mentioned that much of the work is carried out locally, but there are some state actors that are involved in sort of the day-to-day carrying out of the work as well. We have disease investigation specialists who help particularly with conditions like HIV and other significant public health outbreaks. And the State Laboratory of Public Health provides laboratory services that support the diagnosis of communicable disease and conditions in the state. At the local level, the law gives a number of specific disease control duties directly to local health directors. So every county in North Carolina is served by someone who's called the local health director. They might be a county health director, or they might be a multi-county district health director responsible from anywhere from 2 to 8 counties. But every county in the state has someone who is in the role of local health directors. And they have a lot of authority under the communicable disease laws. I'll be talking later. They can exercise isolation and quarantine. They can do other things. They might exercise those duties themselves, or they might delegate them to someone else in their health department. And so it's possible that you guys in the role that you serve might work with your local health departments on a communicable disease situation or response, and you're likely to be working with the delegees of the local health directors who've been delegated legal authority to do what they're doing. Local health directors oversee the work of the local staff, and they receive reports of communicable diseases and conditions. They do local investigations, and they're also the people who are primarily responsible for ensuring that people know what communicable disease control measures they're required to comply with, and for ensuring that people do in fact comply with those communicable disease control measures, or have the laws enforced if they are not. Let's go to the next slide, and I'm going to give it real short shrift because I got started late with my tech problems, and I want to get into the meat of our stuff here. While most of what I'm talking about today is in state law, there is some federal communicable disease law that becomes quite important when we have something like SARS or MERS, Middle Eastern Respiratory Syndrome, or Ebola, where the disease originates elsewhere in the world and gets imported into the United States. For example, it's the federal government that can take actions related to the national borders, such as the screenings that we had at airports during the Ebola outbreak of the pandemic in 2014. We had screenings going on at airports to identify people who might be sick before they got on planes. The federal government is the one that's got the authority to do that. The federal government also has the authority to take some actions to prevent or control the interstate spread of disease, like from North Carolina to Virginia or to South Carolina or what have you. But most of what the federal government does with most of our day-to-day communicable disease activities is they're providing preparedness, they're providing support and assistance to the states in a variety of ways. For example, they develop the case definitions that are used for identifying the communicable diseases that have to be reported. So, you know, you've got your case definition that lets you know whether or not a report needs to be made. They also are the first ones out of the box developing control measures when we have a communicable disease outbreak or an emerging communicable disease that requires response. So I'm going to give a little bit of short shrift to federal, but I did want to acknowledge that they are there. And let's move on to the next slide, which is a transition slide. So we'll be on this quickly. We're going to take a closer look at some key legal issues. And let's just go right on and dig into what those are with the next slide. As we go through the key issues, I wanted to note that the issue of confidentiality is going to come up over and over. So I wanted to lay out the basic principles of confidentiality law at the outset and then get more into it, into the specifics as we look at the individual key core issues that we're going to be focusing on. So what the left-hand side of this slide shows is that there are multiple sources of confidentiality laws. So, for example, you see up at the very top HIPAA, which I'm sure everyone is familiar with and been trained in and so forth, and that's a federal law. And then if you keep moving down the left-hand side of the slide, then there's state public health laws as well. I abbreviate that PH, that's public health. And then other laws. Sometimes there are other federal or state laws that come into play in understanding confidentiality as well. And all of them have to be considered together at the same time in order to answer communicable disease confidentiality questions. Some of the basic aspects of these laws that will come up in our discussion are outlined on this slide. And I just want to make a couple of points about that. First, about HIPAA. This is our foundational confidentiality law. It covers all kinds of individually identifiable health information, including communicable disease information when it's individually identifiable. It has, as I'm sure you know, if you've been through the training, HIPAA has a lot of rules about when you can disclose information, when you need authorization, and so forth. Just two of the rules that I would like to draw to your attention because they're really important to the discussion of communicable disease laws. One is that HIPAA specifically allows disclosures of information without the patient's authorization, so they don't have to sign anything, when it's a disclosure that is required by a state law. Remember, HIPAA is a federal law, so it's one level of government, but we also have these state laws. And sometimes we have state laws that require disclosures of health information. A great example is the laws that require physicians and others to report communicable diseases to the local health department. HIPAA doesn't say that you have to report diseases to the local health department, but what HIPAA says is that if you have a state law that says you have to report diseases to the health department, and we do have a law like that in North Carolina, then HIPAA says, yeah, we're going to allow that disclosure of information, and we're going to allow it to be made without the patient's written authorization. Nobody has to sign anything. The disclosure can be made because that's serving an important public health function. So A lot of our communicable disease laws have built in some required disclosures of information to public health. So I just wanted you to be aware that sometimes people say, isn't HIPAA a barrier to that? And the answer is no, HIPAA is not a barrier. And the main reason it's not a barrier is because it allows disclosures when they're required by state laws. And it also allows disclosures even when they're not specifically required by state law, if the disclosure is needed to carry out particular public health purposes. So one way or another, when we're dealing with communicable disease and disclosures of information to public health officials, you can usually get there one way or the other. Sometimes the analysis is a little thorny. So that's an important principle to understand about confidentiality. The information about people who have communicable diseases, the individually identifiable information, it is confidential, but that does not prevent it from being disclosed to public health officials so that they can carry out their public health duties. You can't disclose it to just anybody, but public health officials can generally get that information so that they can do what they need to do to control the communicable disease. I've already talked about state laws. Moving down the slide here to the next category, I've already talked about how they require certain disclosures. There's mandatory reports. There's some laws that address access to medical records in outbreaks. I'll talk about that a little bit more later. The only other thing I want to point out at this time is that state law also protects communicable disease information that is given over to public health so that they can carry out their public health duties. It protects it from being redisclosed improperly. So that's another important thing that our state law does. And then we have other laws that may affect confidentiality and what we do in communicable disease. And all I want to say about that is just to be aware that they exist, because although HIPAA and state public health laws support access to information for communicable disease activities, other laws may inhibit that access or may give you a different answer to a confidentiality question if you have one. Okay, so let's get into the core legal topics of communicable disease law, starting with the issue of reporting communicable diseases to the local health departments. In North Carolina law, our law provides for both mandatory and voluntary communicable disease reporting, and it provides for both routine and non-routine reporting occasions. So I've sort of got the slide set up that way. I probably ought to have done it in the form of a matrix so you could see mandatory, voluntary across one axis and routine and non-routine down the other, but this setup sort of gives you that look at that. Let's start with mandatory routine reporting, which is in the upper left part of the slide. We have state laws, I've mentioned these already, that require physicians and certain others to routinely report more than 70 communicable diseases and conditions. This is a number that can change and that has changed over the course of my career. When I first started working, I think we had about 63 communicable diseases that were reportable in North Carolina. We added an awful lot in the early part of the 21st century and the aughts of the 2000s. But we've been pretty stable at 75 for a while now. The list of reportable communicable diseases is adopted as a rule by the Commission for Public Health, and you can find it in the North Carolina Administrative Code. The types of diseases that are reportable in North Carolina include those with public health significance, such as tuberculosis, HIV, the various forms of hepatitis, most of the vaccine preventable diseases, sexually transmitted diseases, foodborne illnesses, illnesses that you might get from water that's been contaminated by human waste, mosquito-borne illnesses, flu deaths, novel influenzas, and some others. Now, some of you might be thinking, well, isn't there a federal list? Yeah, there is a federal list of notifiable diseases, and that does influence what's on North Carolina's list. But this is one of those areas where it's state law that actually sets out what is the list for what you have to report in this state, and those are the types of things that are on our law. In addition to physicians, other people and entities who are required to make communicable disease reports include laboratories, school principals, child daycare operators, and people who are in charge of restaurants, with the caveat that the restaurant folks are only required to report foodborne illnesses, so they don't have to concern themselves with the whole list of 75, just the ones that might be transmitted through the food that they're serving. The law specifically gives the duty to report in the healthcare environment, it's the physician who specifically has the duty to make a report of a communicable disease to the local health department. Other categories of healthcare providers aren't mentioned in the law, but if another category of providers, such as a nurse practitioner or a physician's assistant, suspects a reportable communicable disease in a patient, then that practitioner should notify the supervising physician to ensure that the report of the communicable disease is made. Or in some healthcare facilities, it may be that there's been a practice of delegating the duty to report to another practitioner, and I think that's fine. I don't think it's a problematic practice, so long as the delegation of making the report has been made to an appropriate person. And by appropriate, I mean someone who can provide all the relevant information and who's also been included in confidentiality training and in confidentiality policies and knows what they're supposed to do as far as keeping that information protected the way it is supposed to be. Physicians should be aware that their duty to report and any liability associated with reporting does always go back to them, even if they've delegated the duty to someone else. But I think in practice, this duty is delegated a lot, and that's fine as long as it's done properly. I think people are generally aware of mandatory routine reporting, but perhaps less aware of non-routine mandatory reporting. We have a state law that allows the state health director to issue a temporary order requiring healthcare providers to make certain kinds of reports. So this type of order might require reporting a particular disease or certain kinds of symptoms or trends in prescribing or other uses of healthcare services. So the law that authorizes that was adopted to address emerging illnesses. For example, there might be a period of time during a new outbreak when we know something's going on, but we aren't sure what it is, and we want to monitor symptoms while we figure it out. And so one way that the state can gather information about that is to issue a temporary mandatory but non-routine order that something has to be reported. I'm going to skip over voluntary reporting and use our time on other things. So let's go to the next slide, and what you'll see there, we'll just take a real quick look at it, is this is an example of what a temporary order looks like. And this was issued under a previous health director, so that's not Betsy Tilson's signature, but this is, it's very, it looks informal, as you can see, but it has the force of law. When the state health director issues an order saying, I want you to report this, then healthcare providers must be attentive to that, and they must report whatever is in the order. And in this case, this was an order requiring reporting of Middle Eastern respiratory syndrome. It is a temporary order because what this allows the state health director to do is go ahead and get the reporting requirement out there while they go about the somewhat protracted process of adding this disease to the reportable communicable disease list. So this temporary order has expired, but MERS is still reportable in North Carolina because we got it added to the communicable disease list. Let's go to the next slide. This is the final slide on reporting. And it is simply a chart for your reference of who has to report what, when, and to whom. And it gives you the citations to the laws that impose the reporting requirement. And it is not something that we should read through now, but it is for your later reference. Next slide, I'll say just a word about confidentiality and mandatory and voluntary reporting. Because I do get the question a lot of whether confidentiality laws prohibit communicable disease reporting that's required by law. And as I tried to lay out earlier when I talked about the different kinds of confidentiality laws, generally the answer to that question is going to be no. HIPAA specifically allows reports to public health that are either required or permitted by state law, as we discussed, and everything that we talked about in this section on reporting is either required or permitted by state law, so we don't have a HIPAA problem. On top of that, I know that sometimes healthcare providers say, well, maybe I don't have a HIPAA problem, but couldn't my patient still sue me if they think that I have violated their confidentiality? That's a legitimate legal concern, but North Carolina state law has taken care of that for our providers by providing immunity from liability for healthcare providers who make the reports that are required under these laws. So we can feel good about that as well. And then finally, we also have a state confidentiality law That's really important because all of those other laws that require reporting, they send information to public health officials. This last law on the slide, that's the one that says to the public health officials, when you get that information, you're obliged to keep it confidential too. And you've got to take steps to make sure that it is not redisclosed improperly. That doesn't mean they can't ever redisclose it. It just means that they've got a set of rules that they, meaning public health officials, that they have to follow. Now I need water, and we are under water restrictions in Chapel Hill, so I am, for the first time, opening my water bottle. If you'll give me just a moment. Thank you for your forbearance. And let us go on to the next topic, which is communicable disease investigations. And I'll tell you that I just don't have much to say about this because most of it is practice and not law. And so public health officials at your local health department and the state health department can tell you a lot more about this than I can. I think you're going to learn a lot more about this. I think that you've got things on your agenda that will get into more detail about what these look like in practice. There is a legal issue in investigations that I do like to take just a moment to address, and it's another informational confidentiality kind of issue. So I'll take just a second to talk about that. We have a state law in North Carolina that requires the local health director to investigate cases and outbreaks of communicable diseases and conditions. And as part of that, it specifically says that a local health director or the local health director's delegated person or the state health director or the state health director's delegated person can actually go into a healthcare facility and look at their medical records. And they can look at the public health official is the one who can say, these are the records that I need to see because I have determined that they are related to a particular case of communicable disease that I'm investigating or a particular outbreak of communicable disease that I'm investigating. And they have the legal authority to demand access to those records and to see those records. Now, your HIPAA officer would and should tell you, well, before they get to see those records, we're going to verify their identity and we're going to verify their legal authority to see those records. That's appropriate practice under HIPAA. But once you get to the end of that verification, if they're really who they say they are, they're a public health official, and they're really there for the purpose they say they are, to investigate a communicable disease case or outbreak, they can have access to records, even to just go in and do something that's like a fishing expedition, looking for people who have had pneumonia-like symptoms because we think maybe we've had anthrax in the state or something like that. They do have the legal authority to do that, and I wanted to make sure that you're aware of that. I've got two different laws that are listed on this slide because we've got one that applies to communicable diseases specifically. And then we have another law that allows that requires healthcare providers to give local public health officials access, local or state public health officials access to information when it is needed to investigate something that might have been caused by an act of terrorism that's biological, chemical, or radiological in nature. I don't think that we have used that one in North Carolina, but it's there if we were to need it, if we were to have a repeat of the anthrax letter attacks of 2001 or something like that, we might be operating under this law. Bottom line on both of these laws is that they give public health officials the authority to demand access to medical records and information, and healthcare facilities and providers after going through their appropriate HIPAA processes of verifying identity and authority, need to provide access to that information. On the next slide, I've got the confidentiality summary again, because that is the type of authority. The authority to just go look in the medical records is the type of authority that tends to make people ask, well, what about HIPAA? And so that's a good question. And here are your answers. Again, HIPAA allows disclosures to public health. These disclosures should be only being made to public health officials who can prove that that's who they are. That's what verifying identity and authority is about in part. But HIPAA allows those disclosures when they're required by state law, and the laws that were on the previous slide are state laws that require disclosures. Again, if the question about, but couldn't I be liable in a civil suit or something were to come up, the healthcare provider is protected from liability for disclosures that are made in accordance with those laws. And again, public health officials are subject to a state law that requires them to handle the information with the concern for the confidentiality of it that is warranted. All right, let's go to the next slide and talk about communicable disease control measures. North Carolina has a state law that authorizes the Commission for Public Health to adopt rules prescribing control measures, and then it goes on to require all persons to comply with the control measures that the Commission adopts. The Commission's rules are in the administrative code, and that's what that incredibly messy citation, I just gestured to it and then realized you couldn't see the slide, you could only see my hand doing this, but on the right-hand side of the slide, that long gobbledygook of numbers and letters is a citation to the North Carolina Administrative Code, and that's where you find communicable disease control measures. If you ever read that part of the administrative code, which some of you may as part of your work at some point, you'll find that it sets out specifically what the control measures are for some communicable diseases, particularly the ones that you see listed on the slide, and I won't read them to you. You can read that for yourself. Now, that is only a handful of communicable diseases. That's not all of them. So where do the communicable disease control measures for other communicable diseases come from? The rules say that for all other communicable diseases, we're going to look to other sources to figure out what our communicable disease control measures should be. Specifically, the rules tell you to look to these sources. First, you look at CDC guidelines and recommended actions as the primary source, if those exist, and usually they do. But if for some reason they don't, if there's nothing on point from the CDC, then the next source is the American Public Health Association's Control of Communicable Diseases Manual, which is now in its 20th edition and is available by digital subscription as well as in book format. So there are three specific issues related to communicable disease control measures that I wanted to say a little more about. First, I wanted to say a word about isolation and quarantine. And second, I wanted to talk about the issue of control measures for emerging illnesses. And then finally, I wanted to address bloodborne pathogen exposures. So let's take a quick look at the next slide on isolation and quarantine. I've got them under control measures because they really are a subcategory of control measures, but they warrant standalone treatment because they have unique qualities and some of their own laws as well. So the questions that information that I have about isolation and quarantine are oriented around are the ones that you see here. How are those terms defined? Legal definitions matter a lot to those of us who work with law. What distinguishes them? Who gets to order isolation and quarantine? How long does an order last? And how can it be enforced? On the next slide, we'll take a look at that first question about how they're defined. The key distinction between isolation and quarantine is that isolation is for sick people and quarantine is for exposed people. That's not the only legal distinction, but that is the rule of thumb distinction that gets you 90% of the way that you need to go in most cases, even for legal purposes when we get in the legal weeds. So isolation is for the sick and quarantine is for the exposed. Our popular media does not get this distinction, I don't think. They tend to call it all quarantine. And for popular media purposes, I think that's fine. It doesn't really matter. But for legal purposes, it's important for the people who order isolation or quarantine to get it right and know which one they're ordering, or else their order may turn out to be invalid. So whichever term that you use, if you think about the term isolation or quarantine, it may be that for you it evokes the idea of a person being physically separated from other people. And that's totally understandable. That is the classic definition of these terms. That's what they meant. But in North Carolina law, we do have that concept of physical isolation, but we also, confusingly, and just to keep things interesting, in North Carolina, we use the terms isolation and quarantine to refer to orders that require a person to comply with all kinds of communicable disease control measures, not just the ones that involve physical separation of a sick or exposed person from the public. So this can get really confusing. Let me take a minute to break it down and introduce some other non-intuitive, confusing terms to you. Something that's unusual but really important about North Carolina isolation and quarantine law is that it distinguishes between what we call freedom of movement and freedom of action. And it's important to recognize this distinction because there are different laws applying to the different kinds of restrictions. So, an order restricting freedom of movement tells a person to stay home or to stay in a healthcare facility or don't go to work or school, or it otherwise restricts a person's ability to move about freely in society. It doesn't have to do all of those things I just listed. Those are just some examples. Stay home, don't go to school, etc. Any of those restricts your freedom to move freely in society, which most of us usually enjoy. That's a constitutionally protected interest that we all have. And an order affecting freedom of movement gets in the way of that and says you can't go where you want to go. We sometimes refer to this as physical isolation or quarantine. So it's basically that concept of isolation, physical separation that we tend to have in mind anyway when we think of isolation and quarantine. But in North Carolina, we also use the words isolation and quarantine to refer to orders restricting freedom of action. And these orders don't affect where a person may go, but what they do instead is they restrict how a person behaves. It generally boils down to an order telling someone that they have to comply with the communicable disease control measures, which may mean that they have to take a test, or they might have to take a medication, or they might have to constrain their behavior in some way. For example, we're going to look at HIV control measures in just a minute, I hope, if I don't run out of time. Oh, I'm out of time already. Okay. For example, HIV control measures have some provisions that were updated this year about use of condoms and notifying sexual partners. Those are particular behaviors that people have to engage in. In North Carolina, when we need to enforce those control measures, we will issue something called an isolation or quarantine order, even if we're not physically separating the person from the rest of society. And I think that's what makes it so confusing. In fact, I have even asked my friends who work in the State Division of Public Health, would it be possible for us to amend the state laws so that we have something called an order to comply with communicable disease control measures? Because that would be so much more intuitive and easier to understand. But what we do instead in North Carolina, since we don't have anything like that, is our public health officials will issue something called an isolation order, even if the order doesn't physically isolate the person, but it tells them you have to comply with these particular control measures by changing your behavior. We're going to call that an isolation order, or we're going to call it a quarantine order. So I'm sorry for starting to run short. I know that probably wasn't crystal clear. At this point, I said I'm not in the business of selling books, but I'll sell you a book. I've got a book on North Carolina communicable disease law that has a chapter on isolation and quarantine that explains that in more detail. Let's skip over the next slide, which just sort of briefly goes over who can order isolation and quarantine and how it lasts. And let me take if I can have 5 more minutes, if that's not okay, give me the high sign and I'll shut up at any time. But the other couple of things I wanted to address on communicable disease control measures. One was control measures when we have an emerging illness, a new or an unusual illness such as SARS or the novel H1N1 flu virus of 2009 or Ebola or something like that. I've said a couple of times now that all persons are required by law to comply with control measures, but in the case of emerging illnesses, we don't always have control measures when the illness first appears. We're learning as we go along. I just leaned over to look at my chat. I'm looking at 3 screens and it said I'm okay on time, so I'll keep talking. What tends to happen with emerging illnesses is that the control measures are going to evolve and they're going to change as understanding of a new or emerging illness develops over time. So this makes a lot of sense. It's actually quite nice, I think, that our laws are flexible enough to deal with evolving control measures, but sometimes it gives us a little bit of a practical problem. You'll recall a couple of moments ago I said that when we don't have the control measures set out in North Carolina rules, then you look to CDC guidelines for what the control measures are going to be. And as CDC understands the disease better, they're likely to change those guidelines. And we've had a couple of examples where that's created a little bit of practical issue on the ground for us in North Carolina, even though it's ultimately been a good thing. Couple of examples, this actually wasn't out of North Carolina, but in Texas and throughout the country, with the Ebola outbreak in 2014, our personal protective equipment guidelines were revised after the healthcare workers in Texas got infected, and we realized, yeah, those just aren't good enough. So they were revised. So that's good. That's positive. We're using science to drive our policy, but it meant that that the law also changed on a dime, which law doesn't usually do. So I have found that healthcare providers seem to be fine with this and adapt to it better sometimes than their lawyers do. So just between us, I'll tell you that. H1N1 in 2009 was another example where we had evolving control measures. When it first appeared, the CDC was recommending school closure if you had a single case of influenza-like illness in a school. That was the advice for only about 1 week before the CDC backed off from it and changed it. But during that 1 week, we had influenza-like illness in North Carolina in a person who had been in Mexico the week before, and we ended up with a school closure. So these evolving control measures are something that we have to keep our eyes on, and things change for good reasons, but that they also can change really fast. So that's, and sometimes that's a bit of a struggle for the lawyers to keep up with. On the next slide, I wanted to address an issue that comes up a lot in healthcare facilities, and since it's thrown in at the end here, I'm gonna run out of time, but I do want to address that it comes up a lot, and that is the issue of bloodborne pathogen exposures. You've probably heard about these and have some familiarity with them. What I have on this slide is I'm just acknowledging that there's two different kinds of bloodborne pathogen exposures that our laws address. We have the occupational exposures, which are the ones that you may be most likely to see in healthcare facilities, and those are addressed by OSHA rules. But then in North Carolina, we also have some state communicable disease rules that address non-occupational exposures, or what we might otherwise refer to as a community exposure, because sometimes those happen. Somebody will, a child will find a used needle in a playground and prick their finger on it. And that's an example of a non-occupational exposure, and we do have some rules around that in North Carolina. On the next slide, I make the point that which law do you follow if you have a bloodborne pathogen exposure? This can get kind of tricky and complicated, because which law you look at to figure out what to do depends on whether it's an occupational or a non-occupational exposure, which is why I make a point of pointing out the difference between those two. So knowing which set of laws you're supposed to look at sometimes is a little difficult to tease out, but the good news is once you figured that out, the two different sets of laws have a lot of common threads and end up leading you to the same ultimate practice results. So if you're a lawyer who's working on this, you're going to want to know which laws you're following so that you get your citations right and you document everything just right and all that kind of stuff. But if you're someone who's involved with applying them to do follow-up with someone who's had a needle stick or some other kind of exposure, you're going to end up at pretty much the same place, because they tend to these laws define exposure in pretty much the same way, and the protocols that they set out for post-exposure evaluation and follow-up are really similar as well. People get tested to see what their status was before they got needle stuck, so they can be tested again later. If we know who the source person is, if we can get our hands on them, then we'll test that person too. And that's provided for in both sets of laws. Providing for different kinds of prophylaxis is provided for in both sets of laws. So they are really similar. And then they're also similar in that they both have universal application. And what I mean by that is that the rules apply regardless of whether you know or suspect that a source person in an exposure has a bloodborne condition like HIV or hepatitis. Because of course you never know who might have one of those conditions, and sometimes the people don't even know themselves. And so we have this universal application of our rules. People who work in healthcare seem to understand that and get that point very easily. I will tell you that sometimes lawyers get their minds blown by it, because it's not part of the culture of law to have a universal application of a rule like this, but that's the way it works. Let us skip the next slide on enforcement of communicable disease laws, because that is really only important to folks who enforce the communicable disease laws, which are our public health people, take an incredibly quick look at the hot topics. The first one is healthcare worker immunizations. And the only thing I'm going to say about that, you can read through this later if you have more interest. I also have a blog post on healthcare worker immunizations that the link to that is at the end of the slides. But I just want to point out that we have had a significant increase since 2009 in healthcare facilities requiring their employees to have seasonal flu vaccination. Of course, healthcare workers, some categories of healthcare workers have always been required to have some kinds of immunizations, but the seasonal flu has been a relatively recent addition to that. When that requirement is imposed, it's usually being imposed by an employer. It's not that often in North Carolina that's imposed by state laws. There's just a couple that are required by state law in North Carolina. You can see that on the slide. There have been some lawsuits around these employer requirements, including one in North Carolina with Mission Hospital, and I just wanted to mention that that one was settled, and what the key impact this is oversimplifying, but the key takeaway I want to make of that is that the Mission Hospital's experience made clear that healthcare facilities that employ healthcare workers and impose flu vaccination requirements do have to provide for religious exemptions as well as medical contraindication exemptions. They can still make you wear a mask if you have a religious exemption, but they do have to make some accommodations for not getting the shot for people who have religious objections. The next slide is about our HIV control measure changes, and this is what I'm gonna wrap up on. Because this is new and important. We do have new HIV control measures in North Carolina. They changed in January of 2018, and the reason they changed was to reflect advances in HIV treatment. North Carolina's original HIV control rules were adopted in 1988, and a whole lot has changed in the 30 years since. And one of the main things that has changed is that we have effective treatments now that can actually result in a person being virally suppressed. And a person who is virally suppressed is no longer infectious. And so if a person isn't infectious, it doesn't make sense, either as a matter of science or as a matter of law, to compel that person to comply with disease control measures that we impose on a person who is infectious. So our HIV control rules basically have been amended to distinguish between the control measures that are required of people who are virally suppressed versus the control measures that are required of people who are not virally suppressed. I noted on the slide, so I'll mention it briefly as part of this. This reflects this. We have a new paradigm around HIV prevention in North Carolina and throughout the United States. And that paradigm is that treatment is prevention. It is a way that we can prevent the control of HIV is by treating it effectively and virally suppressing person. So let's take a very quick look at the next slide. I'm going to note some changes in terminology. Our laws do not refer to HIV positive persons anymore. They refer to a person living with HIV, PLWH, person living with HIV. And they recognize that that person is not considered to be at risk for transmitting the virus sexually if they meet particular criteria that you can read here. So I won't spend any of our time reading them. The final slide on this shows you the differences in the HIV control measures that we have now for persons living with HIV who are virally suppressed versus people who are not virally suppressed. One hopes that that means they're not yet virally suppressed and they'll eventually get to viral suppression, but we do have a distinction in the control measures for these two categories of people. So the two major changes for those who are virally suppressed have to do with preventing sexual transmission. Notification of sexual partners is something that we have required people with HIV to do since 1988. As of January 2018, this is the new rule. A person who's virally suppressed, it's recommended that they notify their partners of their HIV status, but it's no longer required. Now, a person who's not virally suppressed, they're still required to notify their partners, and they actually can have legal penalties imposed on them, and it happens sometimes if they don't do that. Another big change is in the use of condoms during sexual intercourse. For our folks who are virally suppressed, condoms are still recommended for the same reason that they're recommended for all sexually active people, which is in order to prevent the transmission of other sexually transmitted diseases, but they're not required for these folks anymore. For people who are not virally suppressed, people with HIV, they're still required to use condoms with a couple of exceptions that have been carved out to recognize people's realities and reasonableness. One is if they have a sexual partner who's also HIV positive and who presumably they've notified about their HIV status because they're still required to do that, then they don't have to use condoms as part of their sexual activity with that HIV positive partner. Or if the sexual partner is taking our pre-exposure prophylaxis treatment called PrEP, then that is another circumstance in which they don't have to use condoms, nor do they have to use condoms. Obviously, this should be obvious, one would think, if the reason sexual contact occurred is because the person living with HIV was the victim of a sexual assault. So a couple of other changes around organ donation and around the determination of significant risk of transmission, which is going to be very important in the event of a bloodborne pathogen exposure. And you can read more about that because I think I've run out of time. So let's take a quick look at my more information slide. I have a number of links of articles, blog posts that you can get to online if you want to read more about particular topics that I have talked about today. And then on the final slide, or second to final slide rather, I've got, that's what my book looks like, and there's information about how you can order that if you're interested in that. And then the real final slide has my contact information and how you can get in touch with me if you have any questions. I want to apologize for talking fast and running over and having technology problems, and I'm sorry I didn't get to meet you in person today. And that's it for me. Thank you.
Jill, thank you very much. We appreciate it. And if everybody will just hang in there, we'll be back with you with the next webinar in a few minutes. Just get that next link and we'll be with you. Thanks a lot, Jill.